Hans Berger had a near-fatal accident when he was undergoing voluntary military service in 1893. A strange coincidence at the time was to determine his future professional course. At about the same time of his accident, his sister, who was far away at home, suddenly became very worried about him. Her concern impelled their father, without any other reason, to send a telegraph to ask about his son's health. Unable to explain the coincidence, Berger became convinced that the accident had made him into the emitter of telepathic signals. Based on this experience alone, telepathy quickly became a firm component of his worldview for the rest of his life. From 1902, Berger started investigating this mythical phenomenon by carrying out a long series of trials on animals and humans to record electric currents in the brain. This was a pursuit that will lead him to introduce one of the most important investigations of neurology, electroencephalography or EEG. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast. In this edition, we will continue our excursion into epilepsy with an assessment of its investigations and treatments. Berger's research produced only doubtful results in the beginning, but on the 6th of July 1924, he successfully recorded what he called an electroencephalogram with two M's at the end. And in July 1929, after recording more than 1,000 brainwave plots, he published his findings. Unfortunately, Berger's electroencephalogram remained experimental throughout his life, and his laboratory was closed after he retired in 1938. Berger also never got the deserved recognition for his breakthrough experimental work. Whilst he was nominated for the Nobel Prize in 1938, unfortunately the ceremony never took place that year as it was cancelled due to the onset of the Second World War. A sad and disappointed man, Berger committed suicide on the 1st of June 1941 after falling into a depressive crisis. Fortunately for neuroscience, an English researcher called Edgar Adrian, who did get a Nobel Prize, rescued EEG and Berger's reputation from obscurity. After learning about the EEG, Adrian mastered the technique and proceeded to give public demonstrations, which resulted in global clinical adoption. EEG is now an advanced technique with various modalities such as ambulatory, video, and cortical EEG. Another technology that has had an equally significant impact on the management of epilepsy is magnetic resonance imaging. And the two names who have been officially endorsed by Nobel Prizes in 2003 for their roles in developing MRI are Paul Lauterbur and Peter Mansfield. The Nobel story of MRI is, however, not without controversy because one person did not take it lightly when he found out that he had been left out of Alfred's largesse. And the uncelebrated was Raymond Damadian. In his book titled X-Ray Vision, Richard Gundeman explored how Damadian's discontent led to a hotly contested dispute and years of controversy. But let us take a step back from the controversial end and go back to the origin story of MRI. Gundeman traced the history of MRI to 1938 when physicist Isidor Rabi published a paper describing a method of measuring the frequency of the resonance that nuclei generate when they spin. No, you don't need to know what resonance means. I certainly don't. Just accept that spinning nuclei generate something important called resonance. Luckily, the ignorance of what resonance means does not detract from the fact that the method of measuring it was such a breakthrough that it earned Rabi the 1944 Nobel Prize in Physics. And as science marched on, the baton of Rabi's work passed on to Edward Purcell and Felix Bloch. In 1945, Purcell and Bloch almost simultaneously, but independently, described the behavior of hydrogen atoms when placed in a magnetic field and exposed to radio waves. And you guessed right. For their efforts, Purcell and Bloch went on to win the Physics Nobel Prize in 1952. This is the point at which we go back and pick up on the controversy engulfing Lauterbur, Mansfield, and Damadian, all who did sterling work to translate earlier research into practical medical imaging. To protest his Nobel snub, Damadian's friends took out newspaper ads on his behalf, arguing that he deserved the prize. They went as far as to say that Damadian was the leader in the field and that Lauterbur and Mansfield had only refined his technique. Gunderman remarked that Damadian's immodest, boastful, and unwarranted claims may have rubbed the Nobel Committee the wrong way, the result being that the members firmed up their resolve to exclude him. Whatever the truth behind the controversy, what we now know is that magnetic resonance imaging is now an established investigative tool in the diagnosis of epilepsy. For example, it helps in the detection of the structural causes of epilepsy, helping to target them for surgery. MRI also shows the reversible abnormalities that are associated with seizure activity. Before we proceed to the treatment of epilepsy, let us look at one more important investigative tool of epilepsy: genetic testing. The genetic diagnosis of epilepsy has progressively assumed a central place in the management of this very common disorder. And this is partly because it can significantly influence the choice of effective treatments for some types of epilepsy. To illustrate the importance of the genetic diagnosis of epilepsy, let us take a case example, that of Elliot, as narrated by his mother, Claire Audiber, in the memoir titled The Letter E. Shortly after birth, Elliot started manifesting sudden episodes of transient stiffening. His doctors initially suspected that these were neonatal seizures caused by vitamin B6 deficiency. But when his symptoms persisted despite treatment with vitamin B6, the bright doctors considered that this type of seizure was the result of a genetic mutation. And the mutation they had in mind was that of the KCNQ2 gene, a disorder that responds very well to the anti-seizure medication phenytoin. And indeed, Elliot's seizures responded to phenytoin, and his genetic test confirmed that he had KCNQ2 related epilepsy. And this is perhaps the right junction to move from investigations of epilepsy to its treatments. The history of the modern treatments of epilepsy takes us back in time, to a time when phenytoin was not even an anti-seizure medication. Let's go back to Tuesday, the 11th of May, 1857, where a meeting of the Royal Medical and Chirurgical Society of London was meeting, and presiding was Sir Charles Locock, Queen Victoria's obstetrician. Apparently, just in passing, Locock told the gathering that he had been using potassium bromide to treat seizures occurring around the menstrual period, what he called hysterical epilepsy, known today as catamenial epilepsy. And the reason Locock started using potassium bromide was because he had read a German report that this can cause reversible impotence. Locock believed that catamenial epilepsy was caused by hyperactivity of the female genital system. He therefore reasoned if potassium bromide can cause impotence in men, it should be able to suppress the hyperactive genital system in women. Based on this faulty logic, Locock administered potassium bromide to 15 of his patients. And surprise, surprise, all but one of them reported that potassium bromide calmed their seizures. Although Locock did not publish his findings, and even though his account falls short of a scientific study, his eminence was enough to establish potassium bromide as a treatment of seizures. And Locock did not use potassium bromide as a general treatment for all types of epilepsy. Nevertheless, others extended its use beyond catamenial seizures. And by the mid-1870s, the popularity of the drug was such that the National Hospital at Queen Square in London was dispensing 2.5 tons of potassium bromide every year. This is not surprising, as the only competition potassium bromide had at the time was something called tincture of henbane. But any hope that potassium bromide would turn out to be the panacea for epilepsy evaporated very quickly. In her book titled The Sacred Disease, physician Kristen Seaborg pointed out that apart from being ineffective in 50% of cases, potassium bromide also caused severe adverse effects, including irritability, emotional instability, impaired memory, headache, slurred speech, and an acne-like rash. But there was no reliable alternative to potassium bromide until the emergence of phenobarbital in 1912. This was when Alfred Hauptmann published a paper in which he reported that phenobarbital, which was used as a sedative at the time, appeared to reduce seizure frequency and severity in some people with epilepsy. This is the singular report that gave the all clear for scientists to start searching for other agents that may have seizure alleviating potentials. And logically, the drug hounds started by trying out chemicals which had similar structures to phenobarbital. And they were rewarded, even if belatedly, with phenytoin, which was introduced in 1937, the first epilepsy medication that had even a semblance of scientific support. After phenytoin came a surge of what are called the first generation anti-seizure medications: primidone, ethosuximide, carbamazepine, and valproic acid, or valproate. It is notable that carbamazepine and valproate, amongst the most effective of the major anti-epilepsy medications around, were discovered to have anti-epilepsy qualities by chance. For example, when their seizure-producing potentials were discovered, carbamazepine was being evaluated as an antidepressant and valproate was being used as a solvent for anti-seizure medications. After the first generation of anti-seizure medications came the benzodiazepines such as lorazepam, diazepam, and midazolam, which were again shown to be effective seizure-suppressing agents. Then followed a more rational program of screening almost any agent for their effectiveness in suppressing seizures, first in animal models of epilepsy. This expectedly led to the introduction of a raft of drugs which, in chronological order and in one breath, are vigabatrin, zonisamide, oxcarbazepine, lamotrigine, felbamate, gabapentin, topiramate, tiagabine, levetiracetam, pregabalin, and lacosamide. Unfortunately, for many people with epilepsy, seizure control is never achieved using any single or even a combination of these agents. They therefore often go through a macabre dance of anti-seizure medications, moving from one drug to the other or from monotherapy to polytherapy, often in the elusive search of seizure freedom. This situation is graphically illustrated by the story of Kurt Eichenwald, as narrated in his book titled A Mind Unravelled. Eichenwald's story reflects the convoluted journey many people with epilepsy would take towards obtaining seizure control. Eichenwald was initially treated with a combination of carbamazepine, also called Tegretol, and valproate, also called Depakine. But as he continued to have very frequent seizures, phenytoin, also called Dilantin, and phenobarbital were added to his treatment regime. His seizures, however, persisted. He said, almost every other day, I either experienced a convulsion or drop attack, or was recovering from one. At one point, he wrote, my days became a series of doctor's visits to check my blood count, Dilantin and phenobarbital levels, seizures, emotions. He was repeatedly admitted to hospital, and one of these admissions was on account of bone marrow suppression, an adverse effect of his medications. Eichenwald, however, eventually achieved seizure control with a combination of new and old drugs. Not everyone is as lucky as Eichenwald in achieving seizure control. In this case, these are given the dire label of refractory epilepsy. This is when too well-chosen and appropriately used medications fail to achieve seizure control in epilepsy. But even in this desperate situation, there are interventional treatments that neurologists deploy. The first intervention is deep brain stimulation, or DBS, and we have already reviewed this development in another podcast. The second is vagus nerve stimulation, also known as VNS. This intervention was first touted as an epilepsy treatment as far back as the late 1800s, when New York neurologist James Corning developed what he called a carotid electrocompressor. After some faltering attempts in the 1930s, VNS was properly investigated as a potential treatment for refractory epilepsy in the 1980s. This was when Jacob Zabara invented modern VNS. The third intervention for refractory epilepsy is epilepsy surgery. According to Seaborg, the history of epilepsy surgery began in 1909 when Harvey Cushing performed awake surgery in 2 patients. During the operations, Cushing stimulated their brains and evoked sensory symptoms that were consistent with the auras of epilepsy. The next development in epilepsy surgery was in 1912 when Fedor Krauss, who is considered by some as the father of neurosurgery, used the muscular contractions he stimulated to draw a detailed map of the human brain. Seaborg further chronicled the history of temporal lobe surgery starting between 1945 and 1955, when anterior temporal lobectomy became the gold standard of care for medically refractory epilepsy. This was the situation until the early 1990s. Epilepsy surgery is, however, not always a panacea for refractory epilepsy. For example, Kristen Seaborg herself underwent epilepsy surgery, which, however, did not resolve her seizures. But for many people, epilepsy surgery is a lifesaver. This positive outcome of epilepsy surgery is illustrated by Amy Crane in her book titled In My Right Mind. Crane wrote that her epilepsy began with a febrile convulsion at the age of 11 months, and this lasted an hour and 20 minutes. This was then followed by partial and generalized convulsions, which were frequently triggered by consuming artificial sweetness or by the scent of polo mints. She was eventually diagnosed with temporal lobe epilepsy in her young adulthood. Unfortunately, Crane was unresponsive to or intolerant of several medications, including phenobarbital, Depakine, Dilantin, and carbamazepine. She was therefore enrolled into an epilepsy surgery program, and this entailed undergoing precise investigations including inpatient EEG, brain MRI and PET scans, visual fields mapping, and psychological profiling. It also included administering what is called a WADA test. This is the injection of an anesthetic to put one side of the brain to sleep and thereby see how important that side is for language and memory. This measure is to make sure that the surgeon preserves these critical functions during the operation. After Crane's successful epilepsy surgery, she went 2 whole years without any seizures. At this point, her anti-seizure medications were gradually withdrawn. To explore the extreme manifestations of epilepsy and its socio-cultural consequences, I will be speaking to Anne Fadiman, author of the classic The Spirit Catches You and You Fall Down. Thank you very much for listening to or watching this podcast in which we continued our exploration of epilepsy. Apart from the books I have already cited, I've also relied on the following sources for this podcast. The first is by Brody called Anti-Epileptic Drug Therapy, The Story So Far, published in 2010. The second is by Adrian and Ostel, titled The Future is Non-Invasive, A Brief Review of the Evolution and Clinical Utility of Vagus Nerve Stimulation, published in 2022. The third is by Bakigalupi and colleagues, titled Fido Cross, The Father of Neurosurgery, published in 2020. I have also relied extensively on Brainwaves, a book by Cornelius Bork, published in 2018. If you found this podcast enlightening, you might consider clicking on the like button or subscribing to the YouTube, Spotify, or iTunes channel. And if you want to explore neurology further, you can go lowbrow with my book titled Surfing the Brain, or highbrow with my online neurology database called Neuro Checklist. Until the next episode, thank you very much for your time.